we have two young people today who are going to bring their life, their experience, tell a powerful story through spoken word. And the first spoken word artist I'd like to bring up today is a senior from Monterey Trails High School, Issa Jackson. Yeah. Sacramento Area Youth Speaks. We've partnered for quite a number of years, and Issa has a story to tell through his poem. So, Issa, take it away.
Thank you. This blood on the streets is flooded in the SAC. The same spots where young brothers pull triggers for robberies. We start problems in this city, but never studied to finish. Pistols pop, killers cherries, we squeeze fruit for the living. How ironic, that's what we call the city of trees. Around here, girls don't pray, but still get on their knees. Apologize to the youth, I'm just telling the truth. From Meadowview to the P, gunshots will shake the roof. I know a young kid, he's from the hood, grew up in a set. His whole life was surrounded by drugs and sex. He was molested by the older women giving it up. Crazy enough, same girls plotted to set him up. He was jumped, cause one-on-one they ain't have a chance. The kid never walked alone. His best friend was in his pants. He took him out cause he wasn't a runner, he was the man. So he cocked his friend back and said he's ready for real. He said, you crazy if you really think you harder than steel. Reverse psychology is crazy. If you think about it, they were sent to off the kid, but the girls knew he was about it. Getting shot on the spot wasn't really the plan. One in the face, one in the leg, other one ran. That's a murder injury and a witness all in one hand. Crime's a virus in the hood for the young black man. His main man came to kid, furious from the start. He said, don't catch the dude slipping and tear his whole life apart. I said, man, don't start. What you mean don't start? I'll put a hole in his chest and make him speak from the heart. He said, jail isn't necessary. Fight him at the park. It don't matter to the cops, cause at the end my skin darkness is a setup. We found the dude walking and put the bread up. Whoever has his head was guaranteed to get their rep up, makes me nauseous. True killers don't walk to be cautious, just to be cautioned to the fact that killing is just an auction. But often, we watch them get covered in sheets, all up in beef, locked up just cause of these streets they banging. Think about it. Gang signs and sign language to the deaf demon. That's why we kill them for different reasons. So be careful how you walk and mingle. The way they put the iron on him, you would think my brother's caught the wrinkles. But with this gun heat, your best man got your back until you laying on your back against the concrete. We watch they blood ripple flow when the gutters see our street names is different. We ready to fight each other. While our mothers is home making our supper, our fathers are the ink to the pen. It's getting harder, you see. And some of these girls can't touch their fathers. So little boys do the job using their daughters. So who got shot? He got shot. I got shot. We all got popped. We're all the victim of one. See the hood's iconic symbol's a gun. This is a war zone. We worry about war. We in our home, we not. Thank you. Wow.
Thank you, Issa. I had the opportunity before we started today to talk to Issa a little bit, and he shared just how cathartic writing is for young people and those who have the space to express themselves. And I think he said that writing for him, he's seen help save lives. And I just really appreciated that, that opportunity to showcase Issa's work. Thank you so much, Issa. Now I have the pleasure of introducing Sierra Health Foundation's President and CEO, Chet Hewitt. Those of you I see in the room, no stranger to Chet's work in this community and his work beyond Sacramento. A statewide national leader, nationally recognized leader on many different issues that impact young people and their families. I've had the pleasure of working with Chet for going on 7 years. It'll be 7 years for me in September, and have just really appreciated the vision that Chet sets for the foundation, but also his ability to help support the Sierra Health Foundation team and working in the minutiae sometimes, in strategizing and figuring out what the right tactics are to proceed that will help support implementing our mission. So Chet Hewitt.
Before I say anything else, I think we should give Issa another round of applause. That was powerful. Thank you. And Matt is right. You know, we hold this notion of having young people involved in all we do as a value. So it is omnipresence, always with us. And we always try to bring that energy, that thinking, and recognize their contributions into every room that we possibly can. So we are ingratiated by your words today. Also want to do some recognition. I want to welcome all of you. We're a family here at SHF, and I say if you've been here once, you're part of the family. All right? So you come in and walk around the grounds and get your coffee or tea in the morning, whatever, and make yourself comfortable. Because that's what we really want to have happen. We know our conference program, which we're really well known for. We have a lot of folks come through here on an annual basis, and we hold these speaker series because we actually are on this journey together. That's how we think about it. We want to be smarter. We want to be more capable, more confident about what we do. And we have sought to bring in some of the best minds, best thinkers who not only speak from their kind of academic training, but from their experience to help us, fashion our strategies to prove what it is that all of you in this room are actually committed to doing. And that's improving the life and life chances of young people in Sacramento County and beyond. And when I say beyond, that's not some platitude, because I think that while we think about taking and bringing things that other people are doing well to Sacramento, as a foundation, we really think hard about what we're learning and how we put that back into the environment from others to learn from us as well. There's kind of bi-directionality to this particular work, which we think is really, really important. And we really believe that all of us in this room collectively have something to contribute to that national conversation about what must change for young men of color and for young women of color in this country as well. And I know the incidents of the past week are just another graphic reminder of how this conversation, rests so much on tragedy and pain and death, as opposed to really taking the steps we all need to take to advance the conversation, because we know it's the right thing to do. It's a smart thing to do. It's the moral thing to do. So, we take very seriously this work. We're the proud founders of the California Executive Alliance for Boys and Young Men of Color, which emanates out of, this small foundation here in Sacramento and has reach across the state, but increasingly nationally. And I have the great honor of sitting on the National Executive Alliance, which is the 40 foundations nationally who do some of this work as well, who are recognizing Sacramento as a community and a force to be noticed in this particular work as we grapple with the challenges associated with it as well. So thank you for joining us, and thank you to our colleagues in Merced we're streaming to, because we know how important this work is in the Central Valley of California. It may not be LA or San Francisco, but they have some of the worst numbers in the state when it comes to some of these issues as well, which is why we have an office we opened up a couple of years ago, 2 years ago now. So welcome all of you in Merced as well. I will do what I'm supposed to do here. I'll recognize some of our elected officials or their representatives. We have Cassandra Jennings here from Mayor Johnson's office. Thank you, Cassandra. And Candy Pulligan from Kevin McCarty, Assemblyman Kevin McCarty's office. So welcome as well, Candy. I know you're in this room. My job was to introduce John, who, as you see, and I know you have his bio, which is really impressive. He's professor of health management at Drexel University School of Public Health. He's a graduate of Dartmouth, Duke, and the Harvard School of Public Health. A very impressive academic background. He served as the medical director for the Boston Public Health Commission, where he led initiatives on young men's health, cancer, cardiovascular health, and health disparities, which is a central focal point for this particular foundation, what we call our social determinants of health funding and our pursuit of health equity. There's other things I can say about John, but I'm going to actually turn this over and I'm going to tell a story about John, because I had heard about John long before we met from some colleagues who talked about this extraordinary presentation they had seen and this extraordinary individual that they had actually met. And they described his work around young men of color and violence and trauma in ways that I was simply fascinated by. And so reached out to John, I think in 2011 originally, as we were thinking about our Positive Youth Justice Initiative, which is our effort to reform juvenile justice and turn a system that's really about custody and control into one that's really about development and opportunity. And if you think about criminal justice, development and opportunity is not words that come out of criminal justice folks' mouths too often or too easy, because that's a real shift in their thinking. But we endeavored to really pursue that conversation. And John and I talked briefly, and he talked about, busy, and he would consider that and perhaps come out. And I was encouraged by that. In 2012, I was asked to do a panel at Georgetown University with Shea Beltrack, who was a former director of the Office of Juvenile Justice and Delinquency Planning. And he said, Chet, do you have any recommendations for who might be on that panel? I said, you got to talk to John Lynch. He's doing some phenomenal work close by in Philadelphia. Interesting enough, I think John made it to that particular presentation. I didn't, for reasons I had the flu or something, and never made it out there. But John went out, and again, I heard back about how brilliant he was and how inspiring his conversation was. Time passed, and I got an interesting invitation to the Institute of Medicine in Washington, D.C. They were doing a panel was around youth violence. I guess that's why they contacted me as a guest. I'm not a doctor, it's a room full of doctors, and notable doctors at that. And I actually don't like to do a lot of East Coast turnaround trips. I got 2 young sons. I like to be home with my kids, and so flying to Washington and going to a meeting that's 3 hours long and coming back really isn't my cup of tea. But I looked at who was going to be there, and John's name was on that list. I said to my wife, I'm getting on the plane, and I'm going out there. I said, I'm going to see this presentation myself this time. I'm going to be in the room. And sure enough, I showed up. Listened to a number of other folks who were great. Can't remember any of them. Seriously. Don't remember what they said. Don't remember anything about it. Some good data about funding for youth violence and trauma and stuff. But then John came on the afternoon, right after a break, and delivered what I consider to be one of the best presentations and led a conversation on young men and trauma, something that folks really need to hear. Now, I know this was after the break. I came and I sat down. I sat on a second tier, and I was a seat between me and a doctor who was not of color who was sitting there. And I could tell initially he wasn't vibing on the presentation, young black man. But increasingly, he became more interested. And by the time John finished, he reached across that empty seat and he said to me, I used to be scared of these young men. Now I'm just sad for them. And I knew right then that that was a transformative moment in that individual's life. And you knew that something really powerful had happened just in that particular room, just at that particular time. I don't know who he was, and I'm sure that if I see him today, I wouldn't even recognize him. But we shared that moment together, and I think in a really extraordinary way. Now, I'm not a presentation kind of groupie type of guy. I've been to a lot of presentations over the years, and usually when people finish, even if they're very good, I'm not one of the folks who run up to the front of the room and try to get their autograph or say 3 things or tell them how smart I am. I mean, it's just not my style, and it's not good, bad, or whatever. It's just like not who Chet really is. But I was a groupie that day. And John may or may not remember this, but I elbowed my way to the front of that line. Some of those old basketball players, I mean, I knew how to throw a wicked one. It didn't matter gender or anything else. And I remember with great clarity because after his presentation, they were ushering up, and I guess they were going out to some small room for interviews or something. But I managed to get to the front of the line on a small aisle, and John saw me. And he looked and saw my name tag. And he said, Chet, California, I will come. And we reached out to him at that particular point, and he's here today. A great man, great leader, an inspirer for all of us, inspiration for all of us to do even more extraordinary things than we do. I'm happy to call him colleague and friend now. He's also a fellow New Yorker, who makes it even more powerful for me. Please give a warm Sacramento welcome to Dr. John Rick.
Well, good morning. I feel the love. I feel the love. And I would tell you that one of the things I'm most interested in is stories. And as I have studied over time, narrative and different stories, one thing I do know is that there are good storytellers and not so good storytellers. And Chet Hewitt is a really good storyteller. And I tell you, one of the ways that we connect is, and all of us connect around this work, and I can feel it in the room, is that we feel a passion and a sense of urgency. That some things we've known for a long time are suddenly being talked about as though they're new. And they're things that if we had been listening, really listening, we would have heard young people tell us long ago. And so in some ways, those of us, and I count myself among them, who are talking about this are a little bit behind where Issa and Andre are now. And our work is to make sure that we continue to count the fact that we're going to be a little bit behind because we get caught up. And so I'm very much a fan, an admirer of the work that's happening here, to keep that dialogue going and to have this be a more vibrant conversation. And I hope that it will be so today. So, as we begin, one of the things that I would like to do is to highlight the stories of young people. In doing so, though, I always begin by recognizing, from a trauma-informed perspective, that some of the stories that they tell will have resonance with us in a way that can be painful. And so as young people talk about violence, there may be people here who have experienced violence. And so I want to acknowledge that and give you permission that if any of these stories or the way that they're being talked about make you feel uncomfortable, make you feel anxious, you start to feel your heart beating fast, feel free. If you need to step out, close your eyes. Because we're also about taking care of each other and making sure this conversation feels safe. The other thing I want to say is that I come to this as someone who has had lots of privilege in my life. But I began to understand much of what I'm going to tell you about today, and I'm still on a learning curve, as a young doctor at Boston City Hospital. And I had trained across town in Boston at a hospital called Massachusetts General Hospital, a hospital that is world-renowned, but was not serving many people who came from the communities of color in Boston, Roxbury, Dorchester, and Mattapan, a very fine hospital. But after I completed my training there, I went over and looked at Boston City, and it looked, I tell people I didn't take this photo, because even though some might think I did. This is an ancient photo, but when I arrived, this hospital looked pretty much like it does in this photo. And as I made my way around, I realized that in primary care, I saw very few young people of color, young men of color in particular, but they were all over the hospital, in the emergency department, on the surgical wards, in orthopedic clinic, dermatology clinic, having the same problems that young people anywhere would have, but they were somewhat invisible. And so I began a clinic that was focused on the needs of young men because they didn't seem to be getting primary care. And in the process, I began to hear their stories and talk to them and did some surveying of their needs. And I found out that 80% of them were uninsured. 20% said they had never seen a doctor. 25% said they had never in their lives, these are young people over the age of 18, said they'd never seen a dentist. 45% said they had suffered a violent injury in the past, and more than half said they had witnessed a shooting or a stabbing. And I began to understand that these were young people who had experienced tremendous, unspeakable trauma in their lives. And that we as providers didn't really measure that. We were thinking about the typical medical things that you do for folks, check the cholesterol, health education, but we weren't dealing with the realities of their lives. And I'll never forget the day that I was at Boston City Hospital in the stairwell, and I ran into a colleague of mine, Dr. Jonathan Woodson. Jonathan was a surgeon who had also trained at Mass General, had grown up in New York, African-American man, had gone to the Sophie Davis Medical School in New York, and he'd become a vascular surgeon, and he was working in trauma, and he said, "John, we have to do something. Young people come in here who have been shot," and he said, "I took care of a young person a couple of weeks ago. He came in, he'd been shot in the chest. We worked hard, we were able to save his life. 3 weeks later, I'm in my car driving in, and I hear on the news that that young man is dead." He said, well, when they come in, they sit up there in the hospital for 3 weeks, 2 weeks, 1 week, but nobody talks to them. Nobody does anything. We need to do something. And so I began a process of gathering the stories, the narratives of young people who had come in a way to try and understand why was it that getting shot made it so much more likely that you would get shot again. And as I talked with these young people and heard their stories, I was trying to understand this whole narrative story thing, and I had some good mentors who helped me do that. As I gathered their stories, I began to understand that I held in my mind an unexamined assumption about them. So I'm an African-American man. I grew up in Queens, New York. My parents were educated, and they had protected us from many of the things that these young people had seen. But I realized I had an assumption, and my assumption was, and it was shared by many of my colleagues, young people don't just get shot, they get themselves shot. There was a sense in which we were blaming young people for the bad things that had happened to them, and it came out in the way we treated them. And I began to understand that by understanding their stories, we might be able to understand how we could do something better. And I did it in a more typical way of gathering this, doing analysis, trying to understand it. But after a while, these stories began to weigh heavy on me, and I began to think about how do I take these many stories and, in a sense, retell them on behalf of the young people, honoring the stories that they had told. Martin Luther King Jr. said something that you don't often hear repeated, but he said, "Violence is the language of the unheard." So I began to understand that if these stories, if we don't hear young people's stories, if we don't hear their words, they will respond. And sometimes that response is through violence. I came to understand much of that, not on my own, but with the help of a young man named Roy Martin. And one of the most impactful things that Roy Martin said to me as I began to try and understand this, Roy and I had met when I volunteered to be a mentor in an inner city mentoring program, and Roy was in pre-release from state prison. And as we began to talk, he said to me, I just want you to know that your normal is not my normal. That when you map back anything I tell you to your experience, you're not going to understand it in that context. You need to understand what is normal for me. And what is normal for many of these young people is a constant, persistent experience of trauma through racism, through being marginalized, through being invisible, through, in many ways, these young people can detect the nonverbal reactions that others have to them, the kind of recoil that isn't just about the crossing the street when young people approach, but it is a very much a deep-seated reaction to who they are as people, and that is not lost on them. So to understand the sustained nature of the trauma that young people experience, not only by violence, but by what we do. And so I would say to you, if there is a message here, is that the transformation, the first transformation is ours, not theirs. And we'll come back to that. But let's talk about what's normal for young people. And I want to start with the girl story. Because sometimes in this conversation, we don't hold up the fact that young girls experience much of the same types of trauma. And I know in the political conversation surrounding My Brother's Keeper, this has been surfaced. So let's make sure that as we think about this issue in the context of young people of color, and as I talk about it from my experience, we don't forget girls. And if I talk about it largely from the African American experience, that we don't forget the experience of Latino people, of Asian people, of all people who experience this marginalization in the form of violence, or experience marginalization and for whom it emerges as a form of violence. But this is a young woman named Shatira who is going to talk about what normal looks like for her. And what I'm presenting to you is a digital story. Young people who are part of a healing program called Healing Hurt People, a violence intervention program, came together in a workshop, talked about what stories they wanted to tell, and then had control over that story for telling it with their own images and their own voices. And this is Shatira's story. And so Shatira tells us what normal is like for her, and the impression that she lives with, which is that anything can happen to anybody at any time. When we look at violence in urban settings, we see some evidence of that. And here I just want to briefly compare violence in Philadelphia and Boston in the year 2013. Philadelphia has considerably more violence. It's a larger city than Boston. But in each case, you can see, for example, that Philadelphia in 2013 had 246 homicides. In 2006, Philadelphia had 408 homicides, so more than one a day. So you can imagine the impact of this on people in the community. This is almost a daily event. In that same year, Boston had 40 homicides. But if we're only counting homicides, and that is what we tend to do, we tend to look at the paper and feel like, or from year to year, if homicides go down a little bit, we're doing a good job. We're missing the picture because in the same year, there were over 1,100 shootings in Philadelphia, 246 in Boston. And then, in this case, almost 8,000 aggravated assaults that were reported to the police in Philadelphia and over 2,500 in Boston. But that doesn't count the little boy or little girl who has to walk past the yellow tape and the blood spot on the ground on the way to school. It doesn't count the grandmother who's sitting on her porch, who hears the gunfire and wonders if someone in her family has been injured. It doesn't count mothers and fathers who are lying in bed who hear gunfire at night. And so we know that violence and trauma are like a contagious disease. You can be directly affected by it, but you can also be indirectly affected by it, and it can spread through communities. Now, communities have ways of healing, so we shouldn't behave as though in this medical model that we're always bringing the cure, but in order for communities to heal from this kind of violence, we have to be very intentional about supporting those means and advocating where we can. And we'll talk more about hospital-based approaches and others. But a trauma-informed perspective has to look past the numbers and into those affected, those who surround those who have been injured in the community. And just to put an exclamation point on this, if we look at homicide deaths in the United States and compare them to war casualties between the years 2001 and 2010, what we see is that in Afghanistan, tragically, 1,446 people, soldiers, lost their lives due to violence. In Philadelphia, over that same time period, there were 3,391. And in Iraq, 4,430. It's devastating that the level of loss that is being experienced in Philadelphia is on the order of what happens in combat areas. But this is just Philadelphia now. So if we took the same time period, a time of admittedly higher rates of violence than we're seeing now, we see what a loss this is. And it's a loss of capacity and possibility for communities and families. And there's a cost of trauma to those who remain. But there's also a financial cost to this level of violence. And researchers at the University of Georgia have estimated the cost in lost productivity from a single homicide of $1.3 million over the life. And this is because certain people who die young. Any productivity they would have had throughout their lives is ended, and the support they might offer to children and families. For a non-fatal injury, the lost productivity cost is almost $60,000. The medical care per homicide is relatively low, given the extreme state in which many people arrive after an act of violence in the emergency department. But per non-fatal injury, almost $25,000. That means that in 2007, in this nation, we spent $4 billion in the medical treatment of violent injuries and lost $33 billion in lost productivity. Now, I know that your efforts in Sacramento have been helping to bring down the number of homicides and hopefully, though I don't have the data, the number of shootings and violent incidents. And I think those are very intentional action that I understand you've taken together to do that. But even then, if we simply take what I understand to be the number of homicides in 2014 in Sacramento, 29, the lost productivity cost was $38 million. And that's not insignificant for any region. Now, some might say, well, why are we talking about money? And I would simply let you know that sometimes the economic impact is important for policymakers to understand. And we have precious few studies that give us an eye into that. More and more, though, we are looking at the economic impact of interventions, hospital-based interventions and others, so that we can make a broader argument about what we're losing and what we will regain when we pay attention to this issue. So let's return to the issue of trauma and take what you heard from Shatira's story. And I'd like you to hear the story of a young man named David Greene. David, again, produced this story as part of a digital story workshop. And I'm going to ask you to do something specific here. As you hear him, I want you to listen for any words or phrases that he says that just stay with you, stick with your mind, because I'm going to ask you to just call them out to me. Okay? I'm not asking you necessarily to interpret or transform what he said, but can you think about his words, the words he uses, and which ones stay with you, which ones strike you, which ones seem meaningful to you? You with me? Okay, good. Right. So those of you who may have contact with young people, does any of this sound familiar to you? Let me give you an example of where I was and in this. Before I understood this and I interacted with young people who would come in to clinic and I would ask them, what's your day like? And they would tell me that they got up at 1 o'clock. Before I understood this, I would kind of inside, I was like, you got to get up early, you know? It's just tempting. It's tempting to have I'm going to be a coach here. I'm going to tell you what to do. You got to get up early because if you get up early, on and on. If you understand his story, you understand that it isn't about a pep talk. It isn't about someone shaking their finger in your face. It's really about understanding what's happening in your body, in your mind, how you make your way through the world when you have experienced this form of trauma. We often talk about this as post-traumatic stress disorder. And I'm going to talk about that for a minute, but I'm going to come back later to challenge a little bit how we're talking about that in the context of the young people that we see. But for now, let's talk about post-traumatic stress disorder. Post-traumatic stress disorder, or PTSD, was really defined for the first time during the Vietnam War, when returning soldiers had a whole complex or a syndrome of symptoms that had never really been classified before. But if you look at if you read the work of, for example, Judith Herman, Trauma and Recovery, you'll know there's a long history of people who have been in wars, even going back thousands of years, coming back changed. Shell shock, battle fatigue were the terms that were applied at that time. But it really became defined during the Vietnam War. And it has always been thought to consist of three groups of symptoms or experiences. The first is chronic hyperarousal. That's this jumpiness, always on guard, never feel safe, looking around you. Even things that don't seem to us to be threatening often feel very threatening to people who have post-traumatic stress disorder. The second is re-experiencing. That is, nightmares, flashbacks, experiences that take you back to the injury that you had, including what we call body memories. That is, feelings in your body that aren't associated with images, but take you back to that experience, sometimes as pain, chronic pain. And then one we don't talk about as much, sometimes called avoidance or emotional numbing. This is the loss of ability to feel anything. Often is we call it dissociation. That is, you can be talking with someone who has PTSD about something horrible that happened to them or someone else, but they don't look like it's horrible. They look as though they're talking about something very mundane or everyday. What happens often in the medical setting is that providers who encounter young people who have PTSD, who have this kind of affect that's pretty mundane, even though they're talking about something terrible, sort of assume they're not telling the truth. Some doesn't connect for them. So, he was talking about this terrible thing, but he didn't look like it was that terrible. So he must be making it up. If you don't understand trauma, that may be a logical assumption, but it has malignant consequences down the road, right? So part of what you hear in David is that disconnection and these very symptoms that are plaguing him. And so if we walk through, as many of you said, he said, none of the people I knew in the sandbox is alive today. There's been an accumulation of trauma. His cousin was shot while he was lying in his bed, and then is it any wonder that he does not sleep at night, but sleeps during the day when people are around? He talks about nightmares, waking up crying, feeling lonely, wanting revenge. He says, my brother wanted me to hold him. I was crying, panicking. After that, I knew I would get shot, and he talks about changing his body position in an attempt to protect himself, although we know that these kinds of movements wouldn't really protect you from a bullet. So the accommodation that people with post-traumatic stress make to stay safe is often ineffective. But if we put this in the context of post-traumatic stress, he's had multiple traumas. If he's not sleeping, he's hyper-aroused. Depression is as common a consequence of trauma as post-traumatic stress. We don't talk about that quite as much. He has re-experiencing more trauma, hyperarousal, and re-experiencing. So we can recast what happened to him in the context of post-traumatic stress as a way of thinking about it. Now, I will tell you that post-traumatic stress is not limited to soldiers or young people in the inner city. It turns out that studies done in Boston found that 23% of the people who come into a primary care clinic for regular care, all comers, 23% of them have post-traumatic stress disorder. Only 11% of the time does it appear in their medical record as though a provider identified it. Among victims of violence in the inner city in Philadelphia, that rate is 75%. And when you look at the numbers, what we see is in the bar on your far right, 74% of the young people surveyed who were participants in Healing Hurt People had what we call full-blown PTSD. But many of the young people had other symptoms that are associated with PTSD, even though they didn't sort of meet the criteria. And these criteria are very specific. You have to have 2 of these, 3 of these, 1 of these, in order to get the quote-unquote diagnosis. So we have throughout our communities lots of people, and some of us, and this is not to stigmatize, but it's really to understand that all of us experience this because it is part of a normal response to trauma in our bodies. So some of these things, if you have something terrible, if you're in a car accident, some of these things you're going to have, maybe just for a few days. If you have good support around you, and you'll get through it. Anybody have that happen? You in a car accident, right? And you hear it suddenly after a couple days, if you hear another car hit another car, suddenly you're back where you were. Some of this is a normal response that's gone awry. So how do we think about that in the context of these young people? But here's how it plays itself out in the unique settings that many of these young people live. So you're injured, you're hospitalized. But let me tell you, only 1 in 10 people who are victims of violence get admitted to the hospital overnight. 9 out of 10 of those people go home the same day, and they're back in the settings, the communities, often without any explanation or understanding what they're going through. They have post-traumatic stress disorder, but without anyone explaining to them what is happening in their bodies, or let me back up to be precise. They have in those days what we call acute stress disorder, which happens in the first 30 days. But no one's explained this to you. So you're having nightmares, flashbacks, you've lost the ability to feel emotions. You might have lost the ability to feel love for your partner, your family. You're not sleeping. Many of these young people think they're going crazy. And many of the young people we talk to turn to something in their environment that can ease their pain. Marijuana, alcohol, other drugs, as a self-medication strategy. And there is, as you know, discussion about marijuana as a prescribable treatment for post-traumatic stress. So they're not far wrong in their choice of agent here, but obviously the consequences of using marijuana are that it cuts you off from legitimate employment if you go to seek a job at any place where they test your urine, and certainly if you're on probation, having marijuana in your urine will have you remanded. So as these young people without access to care begin to self-treat their distress, they're cut off from opportunity. On the other hand, when you've been shot and you don't feel safe, these young people do not trust the police to protect them. Now, prior to all of the attention that's come in the aftermath of Ferguson, and certainly this week in South Carolina, many people didn't believe the accounts of young people that these things were happening to them, right? Again, they knew this long before the rest of the world has caught up. So not trusting the police or not being certain about which police you can trust is something that you can talk to young people about and understand. And I have found that the understanding of young people is more complex than we would give them credit for. It isn't that all police are bad. It's that you can tell the bad police from the good police, and you want the police at some level. You need the police. These young people aren't advocating for a world without police. They're advocating for a world where police are fair. But if you don't trust the police, as many of the young people told us they didn't, then a weapon may be a logical, though inadvisable strategy to stay safe. So in talking about this, I often say I'm not offering excuses for choices that lead to devastation, but I am offering an explanation as a way to get us to a different place. It may seem logical to get a gun, or to get a gun that you know somebody else holds, you just hold it for a while. But we know that incarceration or death are much more likely if you access a firearm. So rather than simply assuming that recurrent violence is a bad person who was doing something bad, who got shot and then went back to doing some bad stuff, we began to think that's not the only pathway to getting re-injured, that in fact trauma may be a proximal cause of recurrent violence in a particular social context that doesn't keep you safe. So this reality is important as we understand young people and violence in urban settings. But why is it important beyond that? We now know that there's a tremendous amount of research about early childhood adversity and the risk of future chronic disease. So health disparities has a relationship to early childhood adversity. What does that look like? Well, let's hear from a young man named Daniel who talks about his life as a young person and map that onto what we know about childhood adversity. So we know that young people like Daniel grow up with lots of life stresses, mental illness in the family, substance abuse, violence, sometimes physical and emotional abuse and neglect. But we also know that you don't have to live in poverty to grow up in homes with those issues, right? One of the most important public health studies ever conducted happened in the San Diego area in the mid-90s, and many of you know this already, but it's called the Adverse Childhood Experiences Study. Researchers there began to suspect that there was a relationship between sexual abuse that their patients had experienced as children and the health problems they developed as adults. And so they began to survey member patients in the Kaiser system about whether 10 childhood adversities had happened to them. And they had access to more than 17,000 patients, all their medical records, all their pharmacy records, and the like. And they asked them about physical, emotional, or sexual abuse, physical or emotional neglect, and then whether 5 conditions existed in their homes: mental illness, an incarcerated relative, seeing the mother treated violently, substance abuse, or parental discord or divorce. They didn't ask about a lot of things that we might ask about. So they didn't ask about exposure to violence. They didn't ask about police brutality. Many other adversities that might happen to individuals before the age of 18. But what they found was even in this highly middle-class, mostly white group of people, 64% had had at least one of those things happen to them, and 12% had had 4 or more. That was, to their mind, something of a surprise. But more surprising was that there was a direct relationship between the number of adversities as a child and your health as an adult. And it applied to pretty much everything we care about in public health: smoking, alcoholism, drug use, depression, diabetes, obesity, suicide attempts, sexually transmitted diseases, and a number of sexual partners, cancer, heart disease, stroke. All of these things are related in very specific ways to childhood adversity. And it's through stress. It's through the stress mechanism being activated early in life and never quite turned off, a wear and tear effect on the body of stress that many of us might have spoken to and known, but it was affirmed by this study. And so when we look at this issue in clients in Healing Hurt People, as I told you, about 13% of the people in the original ACEs study had 4 or more childhood adversities. 50% of the young people in this program have had 4 or more childhood adversities. In the original study, 64% of the people had at least one. 100% of the participants in Healing Our People have had at least one. And so we should expect, tragically, that these young people will have higher rates of chronic disease as adults and earlier death, and that will be reflected in life expectancy for Black men, Black women, people who live in poverty, those who have lack of access to health care. So this is more than a violence issue. This is a public health issue of tremendous proportions and gives us a window into one of the ways that we can prevent health disparities before they find themselves into the healthcare system, in which case we're only really trying to treat the aftermath of this adversity. So what can we do? What is our role here in thinking about violence from a trauma-informed perspective? And the last story I'll share with you is that of Jermaine McCory, who begins to trace his path. But as you look at this, one of the things we have to continue to hold is the complexity here. There's a lot of complexity when we think about violence, and young people's involvement with what we think about as criminal activity and trauma and stress is complex. The tendency may be to put people in one category or another. There's the innocent bystander, and then there's the deserving victim. But think about his story in the context of those maybe inadequate categories. So how might we wrestle with some of this complexity? A colleague, Dr. Sandra Bloom, who with her colleagues, Ruth Ann Ryan and Joe Fotorero, developed an idea called the sanctuary model, talks about it this way. She said, we mostly have been thinking about these young people or people who've been traumatized wrong. We think about them as either sick or bad. And the idea is if you're sick, it's not your fault at all. You have no responsibility. You need experts to fix you and fix the defect inside you, and the remedy is treatment. On the other hand, if you're bad, it's entirely your fault. It's still a defect inside you. You either stop doing what you've been doing or suffer the consequences. But what if it is that you're injured? And by injury, we don't necessarily simply mean in your physical body, but if you're injured by trauma, well, that's something that's more familiar to us in public health. So if you're injured, if any of us were injured, if you were out for a run and you stepped in a pothole and broke your ankle, you'd have to do some things to heal, right? You'd have to follow the medical instructions, you have to keep it elevated, take your medication, stay off of it. But we as a community would have a responsibility to also understand what had happened to you and what we could do to fix that, like fixing the pothole. So when we think about injury, the remedy is healing. And that's not inconsistent with taking some responsibility for your life and for choices that you've made once you understand it in the context of your trauma. And so one way to get simplicity out of this complexity is this conceptual framework that suggests that people who have suffered trauma need to reestablish safety. They need help managing their emotions. Some of those very legitimate emotions, anger, fear. They need help dealing with loss, not just the loss of function, but also the loss that happens when you choose one path over another. So when a young person comes to understand, I've got to leave behind some people in my life who have not been so positive, that's still loss. We have to count it as loss and help them deal with that in the same way that we deal with losses in our own life. And then finally, being able to envision a future, because if there's one thing that trauma does quite powerfully is to cut off your vision of the future. It constructs a wall that you can't see past. And if you cannot see a future, then it's a little bit hard to weigh off the present against that future as you make decisions, right? So let me give you one example of how to put this into practice. And I use this not as an example of a panacea by any means, but what typically happens is that when a young person goes into an emergency department with an injury, or anybody, we treat their injury, sew them up, and send them out. No conversation, no discussion, no recognition of trauma, no screening. And so in Philadelphia, but also across the country, here as well in Sacramento, hospital-based violence intervention programs have sprung up with a trauma-informed basis to it. And that says we need to help young people heal. We need to make sure that they are connected with the resources that help them get to the future and help them heal. And this is out of the recognition that I suggested to you that the 5-year recurrence rate for violent injury is 44%. If you're shot or stabbed, if you look at those people 5 years later, 44% have been shot or stabbed again, and 20% are dead. This is a health problem that is as much an issue as heart attack, heart disease, stroke. We don't want to miss things that we could prevent. And the Healing Hurt People model is simply this: when someone comes in to your upper left with a violent injury into the hospital, whether they're discharged or admitted, someone connects with them, gains their trust, assesses whether they're safe, explains to them what might happen in their bodies in the few days after this, so they don't take extreme measures. Some of those young people actually want a deeper experience, will enroll in the program, where there's a deeper assessment, case management, mentoring that happens in real time, and then something very important. So I told you about this concept of self. Well, there are groups where young people come together and rethink about their experience in the context of trauma, guided by those 4 pillars. Now, there's this myth out there that young people, particularly young men, will not talk about their feelings. It just isn't the case. The fact is, when you open the space, young people can engage their feelings. They many times don't have the language to understand that anger isn't the only feeling you have. Sometimes anger is really masquerading, is really sadness masquerading as anger. But opening that space is such a simple opportunity that requires nothing more than pizza and some people who care, really. That's the idea. And many of these programs provide these kinds of resources: physical health, family health, social health, and behavioral health resources in a kind of wraparound primary care manner, really making connection for young people, some of whom have really, really intractable difficulties, and some of whom this is like the straw that would break the camel's back, but if we can unburden that, they'll be okay. That doesn't have to only be a healthcare example, though, and we can talk about this, what it takes to make a trauma-informed criminal justice system, what it takes to have a trauma-informed education system. Those are conversations we should have. What's happening now in Philadelphia is this is being replicated across the city in all of the major trauma centers, but that's not quite enough. We need to begin to have the conversation about how we get people together. And so some of our work is about bringing folks together. You can't do this work without evaluating it. And so there is a scheme in place now, as this program is replicated, for gathering control groups in a particularly ethical way. And I want to stop here. The reason I want to spend a moment here is that we have to evaluate, but this notion that the only way we can evaluate is by doing randomized controlled trials is a problem, because if we realize that people need services, to randomize them to no services is a problem. What we've done, though, is to simply say, as we're getting ourselves ready to implement the program at these different places, let's study what's happening before. And then when the program is implemented in a phased way, let's make sure those young people are engaged, so that we're not denying. So there are ways to do the science that is often required by funders while also serving the needs of young people. I would say that in this study, the outcomes that we're looking at include violent re-injury and arrest, but more important are these mental health outcomes. Understanding what happens to your sleep if we give you a trauma-informed intervention, what happens to your sense of yourself. And Dr. Ted Corbin, who's an emergency physician who is leading all of this work, is committed to making sure that we change the conversation away from one that's simply about those numbers that we started with, homicide, shootings. But a lot of bad stuff can happen to you even if you don't get shot again, right? That can't be, that bar is too low to simply ask that of our programs. We have some unique opportunities to engage the young people who have experienced trauma and violence in this work with us. And the Affordable Care Act has opportunity to do that. I know we're still trying to flesh out what that means. California may be ahead of the curve there in thinking about how victim compensation services or funds can be used to support community-based outreach. But we have an opportunity to provide a future for young people by engaging them in this work. Jermaine is now, both Jermaine and Jose, who you see there, are now workers in Healing Her People funded, get this, with reimbursement from the city behavioral health agency. So they're working on a model that says, well, let's figure out, you're doing behavioral health in the context of this setting. Let's figure out a formula for reimbursing those services. That's a very forward-thinking model. Is it enough? Of course it's not initially enough. Sustainability becomes the issue, but as we see policy change that relates to health, and we begin to cast trauma-informed practice in that way, I think we'll find new opportunities for policy change. One of the ways we're working, and Dr. Corbin again leads this, is a citywide case review where we bring together representatives of all of the systems in the city, including police, housing, the school district, the district attorney, the defenders, child protection, and present a case of a child or a young person who has been a victim of violence. You know, there is a model where public health departments do this, but they do it for kids who have been victims of homicide. We began to ask the question, well, could we do that for a child who's still alive and extract some policy understanding but bring a different sense of urgency? And this is something that our partners have been very, very eager to have someone who brings together these systems. The problems are no less difficult, but innovation comes out of that space if we can create opportunities for it. One other challenge and opportunity that I would put out there is that the conversation about firearms seems to almost run on a separate track from the conversations about violence, police mistrust, and others. There is a new opportunity to think about research and understanding the role of firearms in communities. President Obama, several years ago, issued an executive order to lift the ban on federal agency research on firearms. This had been in place for 20 years, which is why we know so little about firearms. This is often a highly divisive political issue, but it is relevant to us if, in fact, we want to think about what it looks like to have a safe community. And so keeping these on the radar screen is critical. So as I end, one of the things that when we started the Center for Nonviolence and Social Justice, we said, we want to change the conversation about violence away from one that's purely criminal justice and toward one that embodies a public health and trauma-informed perspective. And that's a long-term assignment. But I want to return for a minute to this term post-traumatic stress disorder, which is now being more commonly written about in the press and other places, and I talked about it earlier, as you know. Post-traumatic stress disorder implies several things. First, it implies that the trauma is over, that there's a post. And in some cases, that makes sense. It means that you were in a dangerous place and now you're in a safe place. Consistent with what we think about trauma and this word traumatic, it means that your internal and your external resources were insufficient to deal with the threat. and that the body's stress response, the fight or flight mechanism, has been activated and perhaps revved up in a way that's not healthy. But it also suggests that it's an illness, a disorder. It implies that you're sick. That is true for some people. But we're just beginning to think about how would we change that language in small ways to better represent what young people tell us. So we've thought about the term sustained traumatic stress reaction. And while it might not seem terribly different, it refers to, sustained thinks about continual exposure to oppressive, traumatic experiences and environments. It means there's no post because it's always there. Traumatic, I think, remains, this definition was coined by someone named Bessel van der Kolk, who's one of the fathers of trauma theory. And indeed, sustained stress does activate the body's stress response, but most importantly, this is a reaction. This is a reaction to a set of realities that young people are facing. And perhaps PTSD is appropriate in some cases, but what we're seeing more is what we might call STSR. Again, acronyms being limited in the way that they are. If you talk with young people, they'll call this, they might call it being turned up or always on. That's a language that we should understand, that you can tell us what it is and what it will be. But a fundamental idea is, and people have said this for a long time, don't ask what's wrong with me, ask what happened to me. That experiences, rather than some characteristic or attribute, if we can change what happened to you, we can change who you are. And finally, we can change the narrative to say that, yeah, hurt people can hurt people. But hurt people can heal and can help other people. That's where we begin to incorporate the voices of young people. So we have an opportunity. If we believe that violence is indeed the language of the unheard, part of our first work is unclog our own ears through I think, a deliberate examination about what we really default to as our preconceptions. And that, I think, can only happen when we deliberately and intentionally engage and invite the voices of people who've been affected. Their influence here will be more than the sum of our work together. And that is, I think, that will help to change the narrative in a longer-term way.
You don't want to see change, but you want me to be changed. You don't want to see change, but you want me to be changed. You don't want to see change, but you want me to be changed. You don't want to see me prove to the people the system that you haven't said. The education that you deliver is all bad. And this ain't me just spitting some super lyrical truth. This is me listening to the spirit of the youth. You know about them little grades and who you give them to. We know all about your ways. We see the system too. I know real thugs who could be elevating you. There's educated people and educated fools. Now you could care less if I'm fighting with my brother. So tell me, why would they care if we out there killing each other? Sweeping things under the rug we don't see. That's why it always get intense when they hit the street. Because you taught me something once and you never taught it again. Like sex education ain't something we should comprehend. Happy-go-lucky because you and your seat choices. If you know I'm ghetto, then give me more resources. Because I demand the type of living that's a blessing. Not the lesson that you just centered around testing. Keep me motivated and always positive stressing. Like every rhyme, valuable time I can invest in. You don't want to see change, but you want me to be changed. You don't want to see change, but you want me to be changed. You don't want to see change, but you want me to be changed. If you don't want to see change, then you'll forever, ever be changed.
I'm the Executive Director of Community Partnership for Families of San Joaquin. I am the alumni of second class, long time ago. I'm here today because I try to come to all of these convening. There are really great presenters here. So, and this interests me, the topic interests me also. I think one of the things, number one takeaway from this is going back and talking to our behavioral health people, and especially the director, and presenting this information. And looking at it, how can we do some of this work in the region? Because when we are looking at ACE and all these things, we are putting them in silos. So today, kind of we saw over, a large picture of it. So it really helped me to see what do we need to do as a framework in our counties, in our region, to do this work.
My name is Shomari Issa Jackson. I go by Issa. I am here today. I did a poem, a spoken word poem on violence that goes around in the Sacramento community. I am from South Sacramento, and I've experienced a whole lot of violence. And the piece was about strategically and specifically on what goes around in that community. And I used the writing process as healing and communication and therapy. And so my whole strategy is to, for young African American men like me, is to use this as a whole tool instead of the violence aspect. And then we had a huge conversation with Dr. Rich, a nice presentation, and it actually made me feel a lot more, what I was saying, a lot more relevant, that other people can see that as well, especially coming like as a youth, to elders, and then for them to connect and see that. So it was beautiful. Yes, actually I got a lot of, the main thing was perspective. I think a lot of young men and young women, as that, like, they think older people don't see our perspective, but now we can actually see their perspective on what things look like, on the outer shell on things. And it looks like we could actually, once you see the perspective, you could make a connection. And once you can make a connection, you could start building off that connection and start healing. There could be a healing process. And that's what I've got out of it. Like, now we can make connections on certain things between elders and adolescents.